is Director of Community Support Services at St. Toronto. He's an MSL from York University, a PhD from U of T, and has done extensive research into the efficiency of diversion mechanisms for people involved in the criminal justice system. Nupala Chandrasekhar.
Perfect.
I've known her for years. This is the first time I've actually had to say the last name, at least in front of her. So, Nupala is the Director of Public Policy at CNP. She provides strategic policy advice to the Prevention Food Services and Justice Coordinating Committee and is co-chair of the Justice Mental Health Addictions Expert Panel at NIH. And also is Vice Chair of the Mental Health Commission. Okay, well, thank you. Please turn off your phone, sir. Mute phone. Also, evaluation forms, G, or just hold the table and leave it if you can. And if you need education credits on, I'll do that. Thanks.
Thanks so much. Hope everyone can hear us. Thanks for coming on the last day of the conference, right before lunch. We are going to try to finish right on time today, just so we can all catch Minister Nakby. He'll be appearing at 11:15. So today we're going to talk to you about a bit of how social determinants impact mental health and also involvement with the criminal justice system. I'm going to give an overview of really how we look at social determinants in those contexts. And I'm going to talk about how mental health addictions programs really try to address the social determinants. Brian's going to talk a little bit about how justice programs, especially at Legal Aid Ontario, is addressing social determinants. And Mike's going to talk to you about the integration of work, especially in the context of HSJCC and the collaborations that we bring together. Before we start, since I'm a policy nerd, I really like to start with some statistics about really the problem and the issue that we're talking about. So right now, 1 in 3 Canadians will experience a mental health condition within their lifetime. And currently there are more than 6.7 million people living in Canada with a mental health condition. More than 28% of people aged 20 to 29 experience a mental health condition within a year. And when we think about youth, suicide is the leading cause of non-accidental death for young Canadians. And 44% of older adults also experience mental health issues. 500,000 people didn't go to work today because of a mental health condition. It's a very serious issue, and we can no longer be silent about it. A few years ago, the Mental Health Commission of Canada looked at the economic cost of mental health to our economy, to our services, and our programming. And they estimated that the economic cost of mental health is $50 billion a year, which represented 2.8% of Canada's GDP in 2011. And this is costs to our workplaces, to our for-profit organizations, non-profit organizations. When we think about productivity, it estimated to 6 billion loss of productivity in 2011. And that's from, insurance. That number came right from insurance claims. So people off work because of a mental health issue, and that costs really to businesses. And they estimated 1.4 billion each year in costs to the healthcare system, social services, and the criminal justice system. I'm sure you've all seen this map before. It was developed by CMHA, and a few of our colleagues presented on this over the conference. These are the intersections between the mental health system and the justice system, and the juncture points between them, and it's a kind of a visual display of what that journey looks like. So we know that there's a lot of overlap between mental health and justice. I mean, I have to start off that a lot of people with mental health issues never come in contact with the justice system at all. But for those that do, there are serious issues underlying that we need to address. Some of the pieces that we need to think about is, how do we even approach mental health? So the healthcare sector does it in a very different way than the justice system does it. In healthcare, we often look at individual in terms of the justice sector, it's more about the public, right? Public safety, community. So the approach that we take to understanding social determinants is very different. And even when we look at the defining mental health, we look at it in very different ways. So I put up here for you a definition by the Public Health Agency of Canada. And it says that mental health is the capacity of each and all of us to feel, think, and act in ways that enhance our ability to enjoy life and deal with the challenges that we face. It's a positive sense of emotional and spiritual well-being that respects the importance of culture, equity, social justice, interconnections, and personal dignity. And when we think about mental health in the justice context, the criminal code defines it. It's mental disorder is what they identify in the criminal code. And they define that as a disease of the mind. And mental health really comes into play in the justice context when we're thinking about criminal responsibility, the impact mental health has on criminal responsibility. This here is, we call it the two continuum model, but really what it shows is, if we think of the x-axis, you think, you don't, on this end you have no symptoms, and on that end you have many symptoms of mental health issues. And then we think about at the top here on the y-axis, positive mental health and poor mental health. So this means that, it's possible to have a mental health condition and have positive mental health. So you can have symptoms of a mental health issue and have positive mental health. But you can have no symptoms at all and have poor mental health. So we need to really start moving away from defining people as mentally ill or mentally healthy, because the reality is that mental health conditions are episodic in nature. You may have periods of recovery and wellness, sporadic periods of illness. And where you land in this spectrum all depends on what's going on in your life right now and the access to resources that you have as an individual or as a family. One of the main things that impact mental health are life stressors. These are the events in our life that bring about significant anxiety or stress. So we know that negative life events really impact our mental health. So things like the death of a loved one, the loss of a job, or a breakdown in a relationship. But do you know that also positive life events have an impact on your health? So getting a new job, starting a new semester of school, getting married, having children, it all has an impact on your life. And as I was putting this slide deck together, I was thinking about my own life. So in the last 2 years, I got married, we bought a house, I started a new role, and I had a baby. Oh boy. Time for me to get a mental health checkup. And that's really how we need to think about it, right? Like many of us have a physician that we see once a year. We have a dentist we might see twice a year. We might even have a massage therapist that, if we're lucky, we see them once a month. And we need to think about that in terms of our mental health and getting a mental health checkup. And most of our extended healthcare benefits will cover a social worker, right? And then we have a gamut of community-based mental health and addiction providers that, you don't need OHIP, you don't need any kind of coverage to access those services. So we really need to start to shift and change the way we think about mental health and our own mental health care. The other thing that really impacts on our mental health is our access to the social determinants of health. And these are the social and economic factors that influence our mental health, our physical health, and our well-being. And at CMHA and in the mental health sector, and generally actually, we have this saying, and it's in order to have positive mental health, all you need is a home, a job, and a friend. And those are really talking about the social determinants. And social determinants have a variety of levels of impact on the individual. So really there's individual factors that you see at the center, and then we have community and social factors. So what's going on around you in your immediate environment. And then we have general socioeconomic, structural, and cultural factors, which is our society at large. And this image here is from Dr. Dennis Raphael, who we think of as the guru and the grandfather of social determinants of health from New York University. And he's actually identified some key determinants of health and mental health for Canadians. And this is a list here. And I really encourage you to check it out. It's a really great read and an easy read. It's at thecanadianfacts.org. And they go through all the different determinants of health. And one of the main ones really is poverty. I'm going to talk about that in more detail. So at CMHA Ontario, we we partnered with the Provincial System Support Program at CAMH, and we wanted to really understand what are the factors that influence mental health and also influence criminal justice involvement, and what are the main social determinants that really impact on both. And we were trying to understand, in the health sector we call them social determinants, but in the justice sector they may call it criminogenic factors, right? And really we're talking about very similar things. So we thought, why don't we identify a few of those main factors that influence both justice involvement and have an impact on mental health, and delve a little deeper into those. And I want to give a shout out to my colleague, Dorena Simiano. I know she's somewhere in the audience. She was the primary author on this paper. So one of the main components that we looked at is income and employment. We know there's a lot of research that looks at poverty and its impact on health and well-being. We know that, the lower access to economic resources that you have, the poorer your health outcomes will be. And also unemployment and worrying about where money's coming from is a stressful factor, and it has a huge impact on your mental health. And when we look at the impact on justice involvement, lack of access to economic resources it's a risk factor for engaging in criminal activity and criminal behaviors. So this is one thing that's really important. Another piece that's important for mental health and criminal justice involvement is access to housing and impact of homelessness. We know that inadequate or unstable housing can have a detrimental impact on one's mental health. And we know that the same issue, lack of access to housing, is a risk factor for criminal justice involvement. And also the neighborhoods that you live in, these kind of specialized, quote-unquote, high-risk neighborhoods, it's much more majority chance that there will be criminal justice involvement because of precarious housing. Another piece, which is really tied to poverty and income access, is education. We know that education, especially for someone with mental health issue, there can be gaps in someone's education because of the episodic nature of mental health issues. And because there's gap in education, once they kind of enter the workforce or the market, it's much harder to obtain employment. And poor access to education also means it's very difficult to find work, especially work that's stable, not part-time or precarious, stable work with benefits and long-term security. And again, goes back to that idea, education impacts your access to economic resources. Same thing with justice involvement. The level of education really has an impact on engagement with the justice system, and interactions within the education system also influence it. I don't know if many of you were at the session yesterday where Adam Ellis, the ex-gang member, talked about his experience, and he said, his peer group in high school was really the doorway into his involvement with the justice system, and that's a really clear example of the link between access to education and safety and criminal justice involvement. The other two pieces that we really look at in this paper is the impact of social exclusion and discrimination. And I want to take a minute to talk about the impact of stigma and discrimination. Stigma and discrimination are so closely related. Stigma is the negative stereotypes and attitudes that people may hold. And discrimination is the behavior that results from that negative attitude and stereotypes. And there's lots of ways in which discrimination plays out. There's overt discrimination, which is, the acts that you see, the individual acts that you can see on the surface. And there's covert discrimination, which is hidden in our structural society and system issues. Things like that are embedded in policies that are not visible to the surface. And we think about discrimination and its impact on mental health, it's very detrimental. We know that the daily lived experience of discrimination has a very big impact on mental health and actually can lead to mental illnesses and physical illnesses. And we know that there's a lot of aspects of discrimination involved in terms of criminal justice involvement. I don't know, I'll give a recent example. There's been a lot of attention being brought to parking and police street checks. And a lot of that is based in this idea around discrimination and profiling, right? And come out and said that type of practice has to end and has to stop. So we know when we look at individuals who are involved with the criminal justice system, a portion of them, or a disproportion of them, are racialized or Aboriginal individuals. And we can say a very similar statement for people who are in the forensic mental health system, for example. A disproportion of them, of course, are racialized individuals. So we know that discrimination plays a huge impact. And it goes hand in hand with social exclusion. Social exclusion has a huge impact on mental health and also involvement in the criminal justice system. When someone does not feel a belonging to their community, it's so much easier to turn to unhealthy behaviors or unhealthy patterns that would lead to, a life or involvement with the justice system. So these things go hand in hand. And I just want to show this Venn diagram. So if you experience a mental health issue and you're experiencing discrimination as a result of your mental health issue, and you're experiencing discrimination based on other inequities like your gender, your race, or whether you're from the LGBT community. And then think about the intersection of both. So in the center here, not only are you facing inequities because of your mental health issue, but also another aspect of your identity. And if we add a third dimension, you kind of imagine another circle on top is justice involvement. And we know that people who have had experience with the justice system face a lot of discrimination when they get out of the system too. There's barriers to accessing employment and housing, and also there's barriers to accessing mental health and addiction services because there's this new kind of added label and added stigma to the individual that creates barriers. So the next question, I guess what the panel is going to talk about today is how do we help? And one of the most important pieces is to encourage continued integration between mental health and addictions and justice services. We need to leverage existing practices. There's so much going on. I think this 2.5 days of conferences, you've seen programs from across Ontario that are really focusing on this intersection. And again, this idea of partnerships, building bridges across partnerships, working with non-traditional partners, and not just presenting problem for the client, but looking at them holistically and seeing what other factors are influencing this person. The opening keynote, Sheldon Kennedy made a statement that's really stayed with me, and he said, we shouldn't be asking people what's wrong with you, rather what's happened to you, right? And I think that really informs how we think about social determinants, because it really impacts the resources that you have access to, the support that you have, that home, job, and friend really impacts not only your mental health, but also your involvement in the justice system. So with that, I'm going to turn it over to Frank.
Self-identified as a policy geek. I'm going to self-identify as a research geek. So hopefully this isn't too dry. But what I thought I'd do is approach this in terms of existing programs where there's a fairly strong evidence base, or programs where there's an emerging evidence base to support addressing the social determinants of health. In some instances, we're early days. We don't have a lot of data on the efficacy of programs and how they address particular elements of social determinants of health, but there are mapped out strategies that have been recommended by strategic bodies such as the Mental Health Commission of Canada. So I'll be touching on some of these programs that relate to employment, housing, education, addressing institutional discrimination, and promoting social inclusion. addressing income and employment within the mental health and addiction sector, there are programs actually designed to try to address that. They're supportive employment programs, and there's a variety of different models. Everything from sheltered workshops, where it's not in a competitive environment, and it's typically within either a hospital or a community-based agency, to some supportive employment where an individual is actually in a competitive work environment, is getting a competitive wage and is getting some ongoing support to maintain that employment. One program that actually has quite a bit of evidence supporting it, there are a number of randomized control trials suggesting its efficacy, is the Individualized Placement and Support Program, or Individual Placement and Supports Program. It's a mouthful. And essentially, the second bullet really encapsulates what it's about. Historically, a lot of the employment supports really focused in on training, providing adequate training to individuals so that they have their job ready, they have the skills to work in a competitive work environment. This approach turns that philosophy on its head and essentially says, no, let's put the person in the work environment, and they'll be supported, but they'll learn in that work environment. And with respect to the way that the model works, there's an integration between an employment support worker and other clinical support. So the employment support worker is usually part of a team. It could be a case management team, or it could be, for example, an assertive community treatment team. But all the employment support worker does is focus in on vocational supports. So he or she doesn't get pulled away if there's a crisis with respect to another client. Their only focus is on vocational training, and that ensures that it's a priority within the program in terms of addressing those needs. There's a fidelity scale, which essentially means there's been a fair amount of research spelling out specific steps that should be undertaken, and programs that follow those steps will have better outcomes. And in terms of the empirical support for it, the evidence suggests that it leads to longer job tenure and better satisfaction on the part of service users. Okay, so with respect to housing, there are a number of smaller housing programs. What I'm going to be talking to you about is a Housing First model, which essentially it moves individuals who are homeless immediately into housing and wraps supports and services around them. Now, it represents, again, a shift in thinking, or a shift in a paradigm with respect to service provision around how services are provided. Some services historically focused in on housing readiness, so perhaps moving individual from the streets to a shelter, to a high support transitional type of housing, to an independent apartment. With Housing First model, essentially it's putting the individual into housing immediately, independent or self-contained unit with supports, and that could be case management, or it could be ACT. And their participation or their tenancy isn't dependent on participation in services. Now, in terms of support for this type of intervention, there are a number of randomized control trials as well, suggesting about a 1/3 reduction in ED visits, about a 66% reduction in inpatient use, and about an 80% reduction in incarceration. Within Canada, there's the At Home Chez Soi project, which occurred across 5 cities in Canada, supporting many of the findings that already exist in literature. And again, it has a fidelity-based measure, so it's manualized and it can be easily operationalized. Another type of housing support, there isn't a lot of evidence for this, but it's an emerging, promising practice, are short-term residential crisis beds, sometimes referred to as safe beds. And some of these safe beds target individuals with criminal justice involvement. So how they would assist is if an individual is either has contact with a police officer, the police officers are concerned, is it going to lay a charge, individual is homeless, the police officer can bring the individual to the safe bed location, where they'll receive supports and linkage to other services. If an individual is actually before the courts, if they're in custody, sometimes these programs are helped to facilitate bail, so transition into the community, or if a person's in a correctional setting and they're completing their sentence in terms of, again, transitioning them into the community. And individuals can stay currently up to 30 days, and while they're at their stay, there's on-site support, but more importantly, they're linked to longer-term supports with the intent of trying to minimize further contact with the criminal justice system. Okay, so supported education. So these refer to services that provide supports to individuals that their intent is to, or goal is to complete secondary education. And there are different models that are in existence. There's self-contained classroom, where essentially there's a separate curriculum, usually within a post-secondary institution, that may have a vocational focus, but it's a completely separate curriculum, and all the individuals in the classroom are part of that program. You have on-site support model, where essentially an individual is participating or is integrating with the existing course or curriculum, and is receiving support from the institution. So there are counselors on-site that can assist with accommodation or counseling. And then finally, there's a mobile support, which essentially would go to wherever the individual is, be that the academic setting, a home, the community, or if the individual comes into the community agency. As of yet, there's relatively limited research on supported education programs. The early findings are increase retention and completion rates, decrease hospitalization, and improve job opportunities. And as of yet, there's only one study that's looked at the differences across the three models, and as of yet, that one study hasn't found any differences. Okay. So addressing institutionalized discrimination, which really comes to those structural elements that may impact a person's equity of access or equity of outcomes. And this is an area where there is a real dearth of high-quality research. Part of that is because the research that's been done to date has tended to group individuals into clusters which may not be as nuanced or might not be as refined as it could be in terms of helping us have a better understanding of particular aspects of programming or strategies that would have better outcomes. But there is quite a bit of strategy and discussion about how to potentially address, and certainly this isn't exhaustive, this is taken from a variety of sources, but primarily from the Mental Health Commission's Mental Health Commission of Canada's strategy document. They include providing services to individuals, so ethno-racial or linguistic services to individuals, so that the service providers come from the same community as the service user. Indigenous-directed health services, where the entire organization is operated by a member of the Aboriginal community or members of the Aboriginal community serving the Aboriginal community. Attracting more diverse workforce at all levels of the organization, so that the organization more or better represents or reflects the population that it's serving, and actually setting targets for organizations around that. Developing or providing interpretation services is in terms of language. If language can be a barrier to receiving good outcomes in terms of service provision. Training around cultural competency and cultural safety training. The cultural safety training looks at power dynamics between a service provider and service user, and as well trauma-informed care, as individuals from marginalized community may have a higher rate of either immediate trauma or intergenerational trauma. And then finally, in terms of addressing social inclusion, some strategies that the sector has been developing is peer support and service, more broadly, service user engagement. With respect to peer support, I provided a definition here, and it's again taken from a Mental Health Commission of Canada document, but there probably wouldn't be agreement in terms of what peer support is. It can be very individual in terms of what peer support represents to individuals, and there are many different definitions. I'm just using one that's been endorsed by the Mental Health Commission of Canada. There are also different approaches with respect to peer support, whether that's volunteer-based or whether you have a a peer-run organization or peer support programs within mainstream organizations, or peer support programs that are employed by a mainstream organization. There isn't, to my knowledge, a lot of research that looks at the differences across these models and potential outcomes. But the research does suggest that peer support improves quality of life, improves sense of social support, reduces symptom distress, and also reduces hospitalizations. So, subject to any questions. We'll do questions at the end. So I'm going to turn this over to Ryan.
Hello, everybody. Hey, how's everyone doing? Good. I am very good. I am very happy to be here because I'm very excited about this topic of social determinants of health and the justice system. Why am I excited? I'm excited because it's a simple set of ideas, but I think it has potentially a totally transformative effect on the justice system if we start taking the social determinants of health seriously. So what I want to share to you today very briefly is one way that social determinants of health intersect with the justice system, and that's through the work that Legal Aid Ontario is doing, and our thinking around social determinants of health and how we can invest more in social determinants of health to improve lasting client outcomes and help our clients find stability. I was at a conference recently in Ottawa that was put on by the good people at I don't know if you've heard of them, but do check them out. They've got tons of awesome online resources that talk a lot about social determinants of health and the kinds of services that are, could, and should be available to clients in the justice system. And as part of the conference materials, they have this really interesting graphic. Yeah. It was kind of a circle. And in the circle are all these little bubbles. And I was looking over the list of bubbles. Each one was one of the social determinants of health. And what were the bubbles? The bubbles were things like income. Right? The bubbles were things like housing. The bubbles were things like immigration status or citizenship status. The bubbles were things like Aboriginal status as a First Nations Métis or Inuit person. The bubbles were things like criminal history, right? And I was looking at all these bubbles, and they looked kind of familiar to me. And the reason they looked familiar is because most of those issues are right there in the Legal Aid Services Act. All of those are issues that Legal Aid Ontario provides advocacy around. Wow, right? Legal Aid Ontario is a social determinants of health advocacy organization. Wow. Kind of never looked at it through that lens, did we? And then I was looking at all these bubbles and I said, looks like there's one bubble missing. What's the one social determinant of health there that they haven't listed? And what I realized was that bubble was advocacy. Access to justice. It was one of those social determinants of health. So this is sort of the question that Legal Aid Ontario is starting to take a little bit more seriously. And front and center in the mental health strategy that I've been consulting the province on and developing over the last year and a half is how do we double down on the social justice mandate. We know that advocacy improves outcomes, right? It's as simple as that. Advocacy can identify needs. Advocacy can identify options. And I think by taking a rights-based approach to some of these questions, advocacy can actually create the conditions equitably for a client to say yes, for someone to turn the corner and say, sure, I'll try that. Yes, please do help me with my housing issue. So a lot of the mental health strategy is asking how do we act on this imperative. And there's a lot of good stuff that we've got in the strategy, which is coming out early in the new year. And some of the ideas are things like expanding legal aid coverage. So already in June, Legal Aid initiated the expansion of legal aid coverage now to cover first-time offenders who are facing secondary consequences and who have a mental health and addiction issue. So we're shifting, right? We're shifting from being a reactive model, get charged, get criminalized, and then we'll help you, to a much more proactive model. We're seeing, look, now you're at risk, right? You've now been charged, you're entering into the criminal justice system. How do we front end our advocacy services, right? To keep you from becoming criminalized and to help you get out of the justice system and stay out of the justice system. So already we're investing by expanding coverage to make sure that those first-time accused get full representation. Another example, Aboriginal status is a social determinant of health. So recently Legal Aid doubled down on its investment in what are called GLADU sentencing principles. And for those who may not be aware, GLADU is the requirement to bring up the history of Aboriginal involvement with colonization as part of the sentencing process, right? So that judges and prosecutors take into account the history of colonization when they're considering an appropriate sentence for an Aboriginal person. You know, Legal Aid has massively expanded its investment in GLADU and expanded the number of GLADU report writers that are available. Another example is access, right? Why is the criminal courthouse the access point for justice services? That's too late, right? If the kinds of things that trigger criminalization are things like stable housing and stable income, what are we doing to reach those people who are in that precarious position much earlier, before they become criminalized? So some of the kinds of ideas that we have in the mental health strategy are making advocacy available in the community, right? In drop-ins, in shelters, in community centers, so that people can come to an advocate and say, I'm having trouble with housing, before they get evicted. Right? It's not revolutionary. It's not particularly clever, but it's taking this question of social determinants of health seriously. Another example, what do lawyers need to know about social determinants of health? And if lawyers know a little bit more about social determinants of health, how do we make every point of contact with a lawyer or a justice system a meaningful point of contact? So Legal Aid is currently working with CMHA Ontario and the Mental Health Commission of Canada to create a training program that in part is going to help lawyers understand what the social determinants of health are, and how, while a mental health issue or a diagnosis is part of the person's story, it's not all of the story about what puts them at risk, right? Housing puts them at risk, income puts them at risk. So how do we act on that? How do we connect the client with those kinds of advocacy services? So, you know, what we're doing is we're taking a hard look at this. We're taking the question seriously. And I'm very excited that when the mental health strategy comes out early in the new year, that you'll see how we're really shifting to be a lot more proactive and a lot more holistic about advocating for the social determinants of health. Thanks.
I'm as well organized as these guys. I have notes to keep me on track. I tend to wander a little bit, so this might help me a little bit. I first just wanted to give a little bit of a soapbox disclaimer. That is, you know, I'm middle class, had good access to education, never been victimized or anything. I'm pretty lucky, so to be sitting on an expert panel feels almost a little bit awkward because I don't think I am an expert. Like, the true experts are the people who've been through this. I think that's important for us to recognize, just first off. So I'm just going to share my opinions and some still work about the HSJCC, but I wanted to first share with you just a story about when I first got started in this field some 12 or 13 years ago. I was working in Ottawa, and it was my first job. I was an interviewer working at a hospital, and I was going out and meeting with homeless folks in the community and asking them questions about health literacy and things like that. And they warned me when you go out, they said to me, a lot of these guys have been in contact with the justice system or have mental health issues, this kind of stuff. So I'm sort of shit this right now. I'm just out of school. Oh God, look what I'm getting myself into. learned very quickly one very important thing, that people are people, no matter where they come from. And the second thing that I learned that was very important was it was a real problem. I was meeting with a lot of folks that couldn't read the basic materials, didn't have much in the way of education. Huge mental health and addiction component. And a lot of folks that I was meeting with had also been through the justice system. So it became very clear very fast that there's a big system problem here. It became even more clear when a few months later, one of the fellows that I had interviewed, a 53-year-old male, I found him frozen to death on Rideau Street, busy street downtown Ottawa. So to me, that really showed that there's a problem. We need to do something about it. My very work colleagues talked about the social due to the justice system very well, I think. And I'm not really telling anything new in this field. You see it playing out. Why is it that inmates are 2 or 3 times more likely to have mental health in the public? Why is it we talk about 40 to 70% of inmates in Ontario having a mental health issue? Obviously something's crossing over there. There's some great work by a guy, and I just like saying his name too, Vittorio Ardino, who talks about trauma and victimization. So we talk about one of the significant social determinants of health being freedom from discrimination and violence. And Vittorio Ardino talked about in prisons, 70% of the prison population has some degree of trauma and victimization in history. So, very significant. Again, poverty, 40% of our prison population are below the poverty line compared to 70% of the general public. So why are all these things intersecting? I'm simple. So I kind of think about this social determinants of health like an onion. There's many different layers to it, but it's all part of one big thing. So you can separate those layers out, but the more layers you get, well, that's kind of the way I think of it anyway. There's a researcher named Michael Berry who put this together pretty well. He talked about when you're living in situations with elevated stress within your body, your cortisol levels and your stress hormone levels all seem to rise. And if you're living in that degree of stress for a period of time, it takes a toll on you both physically and mentally. That's why you see higher rates of heart disease and physical health issues, but also higher rates of mental health issues. Higher rates of mental health issues comes self-medication and addiction and things like that. He also talked about it being linked with things like unemployment and education. I mean, if you're living in a constant state of stress and anxiety, it's pretty hard to work, go to work every day and do some of these things. So there's really a very clear connection, I think, across there. So Michael Berry, if you're ever interested, brilliant researcher in this area. So saying all of that, tie it back to the HSJCC work that we're trying to do, and most of the people here, I think, are trying to do. And that's really, to seek out and address these health inequalities and social issues, affordable housing, access to being safe, access to education and to jobs, to being part of a healthy social system. And that's what the HSJCC is all about, trying to bring together people from justice, together people from our health and social service sectors to collaborate and try and come up with some solutions or some ways that we can try to improve this for folks. So Hugo mentioned the justice map there, and at those 8 intersections of the mental health and justice system. And that's really where our work, I think, takes place, is trying to link those, bridge the mental health and the justice systems together. And we've done that through great things like release from custody programs. If you don't know what that is, it's for folks who have been incarcerated, who have a mental health issue, but are coming back out to the community. So it offers mental health services and supports that can go into the jails, meet with folks, help with that discharge planning, and help have a continuum of care when they come into the community. community to reintegrate in a positive way. So things like that that are trying to bridge the mental health and justice system in a meaningful way. So there's a long history there at the HSJCC. So I'll give you some examples just of some more current stuff. Affordable and accessible housing has been a big priority for the HSJCC. There's 152,000 which is huge. In most communities, in Toronto and Gary, where I'm from, to get access to subsidized housing, it's like a 6 to 8 year wait list. And often it's harder to get affordable housing if you have a mental health and justice issue. A lot of landlords and folks don't want to deal with it, which is really unfortunate. So at the HSJCC, we've been trying to advocate for more housing and more housing that's dedicated to mental health and justice folks. So we actually did a pre-budget submission to Minister Charles Sousa requesting that more funds be allocated there. So where that's going to go, I don't know, but we've got to push and we've got to try, right? So that's just one example. Also advocating for more safe beds, like Frank spoke about, transition justice safe beds. Folks who are coming out of custody don't have anywhere to go. It's a means of offering people some support, connecting them with case managers, giving them a place to stay until they get their own housing long term. So Toronto's very lucky you guys have some of these services here with CODA, Reconnect, and CMHA, but in a lot of communities we don't have that. So we're having folks discharged from jail to the community with nowhere to go. Again, Barrie, where I'm from, we talk about it as a lot of people being discharged from jail and ending up at our bus station, hanging out there. So not really super awesome. Some other important work, in the realm of advocacy in this area is around police records check reform. I've been fortunate to be part of some work that UPL has done in pushing for police record check information, so non-conviction information, stuff like mental health contacts, to not stay with somebody's record indefinitely, because that can really tarnish you. If you're trying to move on with your life and get a job, or volunteer or get housing, and someone does a criminal record check to find out that you called 911 because you were feeling suicidal 5 years ago, may deter people from renting to you or offering you jobs. So trying to push for some reform in that way, and I'm very positive. I think we're almost there. So also been trying to do a lot of work around prisoner belongings and people getting released from jail. I know Justice and Dr. DeFreitas both spoke about that, people coming out of custody and not having their house keys and to break into their own home, which just, come on, it seems ridiculous, right? It makes it even worse when we think about a lot of folks are coming out of custody who don't have their house keys, have to break into their own home, but also don't have their medication that may be really important that they need to take. So, trying to advocate for a better system around people being released and getting access to their belongings and stuff that they need to get back to their lives. Just some further examples of doing a lot of work with police, and it's been really encouraging and really exciting to see all the work done by Ministry of Community Safety and Correctional Services. And it's, speaking from my region, which is the Barrie County region, we're actually getting approached by our local police detachments looking for more help from us as mental health service providers, to offer education and offer support, and to make those partnerships, which is awesome. So I think in the past it's been sort of the other way around, so it's up to us now to respond and try to do that. So things like CIT training, we now have 750 OPP officers CIT trained across the province, which is a great start. We're also seeing situation tables and hubs popping up in our communities as part of that mental health strategy. Again, oftentimes led by police, which is really to be commended. But it's a chance to get community partners, our justice partners, mental health partners are on the same table to discuss cases and situations that we're all dealing with. So things like that are really encouraging to see, and hopefully we're going to see more of it. I'm giving a 2-minute warning because I tend to talk a lot. If you haven't noticed. Some other promising practice that we're hearing on local levels. A lot of work being done to address transportation issues. A lot of advocacy and training being done on local issues or local communities or local HSJCC. Training CAT, as I mentioned, mental health first aid to first responders. A lot of training being done in the courts, training justices and lawyers around mental health specific issues, which is fantastic to see. Programs like TRIP, the Transitional Rehabilitation Housing Program, which I'm sure folks are probably familiar with, for people who are coming out of regional forensic system back to the community. So offering housing and support and peer support to help people transition better to communities. So there's some great strides being done, I think, in our communities. So we're not out of time, as the license plate on the recording suggests. Still, I'm very positive, I think, about where we're going. We talk about programs like CIT and things, and these partnerships that are being formed. I think we're really headed in the right direction. But like anything, there's still work to be done. It starts with the recognition that social determinants of health, housing, victimization, access to resources, really does play a role in our health, both mentally and physically, in our access with the justice system. So first comes recognition. Second comes, let's have a common language between our sectors, mental health and justice, which I think some of the work at CMHA Ontario with the paper and with training like CIT is starting to do, which is great. Building those local relationships is crucial. And my wife Ashley will laugh because I quoted Gloria Steinem. So see, I do listen to some things. We have to acknowledge that social change is needed. We have to push our governments and our legislators and our lawmakers to start taking this stuff very seriously and to start funding more of these programs, like these housing programs and things that are really going to address these social determinants. But we also can't wait for that too. I mean, at any given day in Canada, there's over 57,000 people in custody with a serious mental health issue. So we can't wait for the laws to change, the policies to change. I think we have to look at how best we can use practices like some of these I've mentioned, or practices that we're seeing, in our regions, to try to make that change happen for ourselves in our local areas. And don't lose the passion for it. I think we're all here because we want things to change for the better. As Rob Nash said yesterday, about finding your why. And I think, for most of us, it's because we're passionate about this field. We want to help people. I think that's the most important thing. So I think together we can start to make some of these changes. So that's all for me. Thank you.
So there are a couple minutes left. If there are any questions. And if you're all in a huge rush to see the minister.
Talk about a little bit the COAST program that you have there on the.
Yeah, sure. I'm so worried about going over time. So COAST program is a partnership programs between mental health and policing. So in most regions, it's either a nurse or a mental health worker who would be on the road with the police, jointly responding to mental health calls to help navigate whether the person should be going to hospital under reform, whether they're going to a crisis services, mental health crisis services. So it's a real partnership initiative. Seeing more of them popping up, which is fantastic.
Stigma because the mental health system, the providers, insist that I'm a person with lived experience, or I'm a consumer, or I'm something other than a person with a mental illness. It's double speak. And it's basically the system saying, don't tell people you have mental illness. Tell people you're a consumer, or that you have lived experience. Doesn't that actually reinforce the stigma? That's something, and believe me, I say this as a person with lived experience, that, you know, I know that I can't force, you know, other people to identify the way I might identify, but at the same time, you know, I compare it to sort of gay rights. Years ago, and people would never acknowledge it, and I see that, you know, over the years, as more people actually said, hey, I'm gay, it became more acceptable. And I think the same has to be done with mental illness, or we can even say mental health issues, whatever.
I think you're absolutely right. I think I very much believe in people need to identify themselves. We need to figure out what we want to be called and self-identify. And interestingly, a few years ago, Ryerson University was offering this course on the history of the Mad Movement. And myself and all of our colleagues in the office, we attended with it. And that language has changed, right? So there are people who identify as mad, or people with lived experience, or consumer survivors, because sometimes it's about surviving the system, right? And I think we need to leave the space for people to self-identify however they want. And I think that language is also evolving constantly, right? I don't think that we have come up with one word to say what we mean. And today, the phrase is people with lived experience, but it might not be that tomorrow.
I'll add the unfortunate thing with people with lived experience is that it's being co-opted by people who don't have a mental illness but have a family member or a friend with mental illness, and they say, oh, I have lived experience. Well, there's a difference between being in a car accident and driving by a car accident. So it's just, sorry, it's something that bugs me. We've got 30 seconds left, so I'm just going to use that time to remind you, please fill out your evaluation forms. Also, the evaluation forms for the whole conference,